Good afternoon, everybody, and welcome to the next episode of our COVID-19 series for health professionals by health professionals. And today we are talking about a very topical and popular subject, which is vaccinations. And I'm very pleased to introduce to you Professor Anthony Harnden from Oxfordshire, who is on the Joint Committee for Vaccination and Immunization. In fact, he's been on that committee for 15 years, he was telling me. And Anthony, let's start off by telling the story about you. We'd like to hear a little bit about you, about how you got into this business from primary care into vaccinations and immunizations, and how do you get to sit on that committee?
Well, thank you for inviting me, Roger. It's a pleasure to be here again. So I trained as a pediatrician after qualification and went into primary care as a GP with an interest in pediatrics. So I was trained in both. And of course, a large part of pediatrics is common childhood infections. And I've set up a research program over the years looking at common childhood infections and also rare but important childhood infections presenting in primary care. And so when the vacancy became available for the GP member of the Joint Committee of Vaccination and Immunization in 2006, because a large part of course, the vaccination program is childhood vaccinations, I applied, and unfortunately David Salisbury appointed me to the position as GP member. And the reason I've been on the committee so long, I mean, usually you're on the committee for a 8-year period, is because they asked me, given my expertise in the area, if I would stay on for another term. And so I reapplied and they appointed me as deputy chairman of the committee in 2015. So it's really a background interest in pediatrics, child health, and immunization related to children initially, which encouraged me to join the JCVI. And it's been a great experience over the years. I've developed a lot of expertise in immunizations along the way, and of course JCVI is quite interesting in the sense that it usually, as a main committee, only meets 3 times a year, and a lot of work is done by the subcommittees. But of course, during this COVID immunization program, we've been meeting twice weekly some weeks, and very, very frequently over the last 6 months. So it's been quite a different experience in many ways with the COVID immunization program than our usual work.
Yeah. A couple of questions coming in about the safety aspects of vaccines that we will come on to. I should say we've got 2,200 people registered for this meeting, and we love your questions, but of course during the interview it is quite difficult to ask too many of them. So I sometimes get criticized for not asking enough of the questions, but I promise you we look at them, and Simon at the end of the month often gets a panel to address some of them, but I'll try and get to those. So the vaccination's been a fantastic success story, Anthony, hasn't it? It's we're second in the world after Israel. America's catching up, I think, quite fast now. But just in your view, I mean, how has the UK been so successful? What are the ingredients of success that's created the current situation?
Well, you're absolutely right, Roger. I mean, the immunization program has almost become a national badge of honor now. I mean, I think there's so many people that have been involved that have really worked hard at this, and right from the vaccine task force, who have procured and ordered millions of doses of a whole portfolio of vaccines, so we've had good supply. Right the way through to our regulator, who's worked really hard at promptly giving approval for the vaccines when all the trials have finished. They've been looking at the trial evidence as they've gone along. We on JCVI have made a lot of clear decisions about policy, but most of all, it's the sort of the vaccinators and the infrastructure that the NHS and I have delivered and devolved nations, and built on that infrastructure that we have mainly in primary care and used to being able to deliver mass immunization programs and through our influenza program and primary care teams throughout the country really stepped up to the mark. They've been absolutely fantastic in the organisation and delivering of this immunisation programme. And of course, then the government have taken on mass vaccination centres and hospital hubs. And I look at our own practice and see how much of a collective effort it's been from all members of staff, through reception, through our practice managers who've worked tirelessly at organising, through the nursing staff, and through the volunteers. I mean, we've had a lot of volunteers that have stepped up to be vaccinators. We also have volunteers to marshal in the car park. I mean, a little story about what happened in our surgery was that actually one of the issues, of course, is we started the immunisation programme in the midst of winter in late December, early January, was that we were having to go on till late in the evenings. And so we had somebody who actually volunteered to floodlight the car park for us. So they gave us a free floodlight system and set up all the lighting, and just bits of help like that, so important, given that we had all these older people coming out in the dark and potential slippery surfaces. And so it's just been a tremendous national effort, and I think we've all bought into this. And it's been shown by the people that are actually having the vaccines themselves. They've been turning up for appointments. We've vaccinated, in the elderly population, more than 95% in many areas. And it just shows you how, as a country, we've made a collective effort to make this vaccination program a success.
I must, in my experience of going into the vaccinations, there's a sort of jolly atmosphere there. The people on the door were happy and friendly. Everybody was ultra professional. It was so well organized compared with many of my clinics that I used to do in the National Health Service. A completely different atmosphere.
Yeah, I mean, I think we've treated people with dignity, and in return, they've been very graceful and actually, hugely complimentary to the staff and immensely grateful for receiving their vaccine. Many people have lived in fear for a long time, and actually just to see the relief on their face as they get vaccinated has been a tremendous privilege. And it gives a feel-good factor for all those teams that are working on the vaccination program.
I think hats off to them. And I think also we were talking before about the role of the media. Media. I think we've got up to about 20 journalists tuning into this program. We usually do, but maybe we should say to them that the media have been extremely responsible in the way that they've handled the issues around vaccination, because I haven't seen much negativity on any of the programs.
Yeah, I mean, as you know, Roger, I've had quite a lot of interaction with the media over the last 3 or 4 months in particular. And I've been really, really impressed with how responsible collectively they've been. I think they've reported stories extremely well. The interviews have all been very fair. I mean, they've been challenging sometimes, but they've been fair. And I think the media have. You're absolutely right. I think they've played their part in the whole national effort, and I applaud them for it, really.
Yeah. Does the JCVI have a sort of comms policy? I mean, who controls the comms around the vaccination program? Is that the politicians, or is it you guys, or maybe is there any control? Pretty hard to control the.
I think it's important to remember that JCVI are independent members. We are an advisory body. The Secretariat is based in Public Health England, so the main comms team is a Public Health England comms team, but obviously they interact with the comms team in the Department of Health and in the number 10 comms team. So it's a complicated communications office strategy. And of course, the other place that's played a big part in this is the Science Media Centre. I mean, they've been really good and stepped up to the plate in terms of the way that they've produced a communication strategy for the vaccination program. So there are lots of different teams. I mean, the main interaction I have is with the Public Health England communication teams, who have been very supportive and helpful.
Yeah. So let's just talk a little bit. Last week, we were talking to three experts, one from Italy, one from Germany, and one from France. And of course, the story in Europe is different. I think it's procurement that's been one of the problems, but also maybe communications as well. We should give a shout out for Kate Bingham, who's, I think, led the way with the vaccine task force. Actually, a date for your diary, listeners and viewers, is the 16th of May. Kate Bingham's being interviewed by Simon Wesley, and she'll tell us the story about how she pulled off those deals to make sure the NHS got not just enough of the vaccine, we got so much of it, we hopefully will be able to distribute it to some other countries in the future. But I mean, any thoughts about other countries and why they're behind the curve compared with us, Anthony, and what can we do about that?
Well, I think it's really important to us, isn't it? Because, of course, what goes on in Europe will eventually affect us. So really, really important. I mean, I think they've made a few errors along the way, not only in their vaccine orders, but in terms of the way that they've approached the deployment of vaccines, in the sense that I've spent a long time justifying our decision for that delayed second dose and the use of the Oxford AstraZeneca vaccine in the older population. And of course, we know it's effective now. There's good data to show that. But of course, earlier on, there were politicians in the continent saying that I think President Macron's on record as saying that the Oxford AstraZeneca vaccine in the elderly was quasi ineffectual, and I think that's incredibly damaging. So I think they've made some errors along the way, but I think we do want them to do well, because we want we want the Europe to be vaccinated and be protected, because it will only affect us. I think other parts of the world have done better. I mean, I think the states have really picked up under this new president, and actually the vaccination program has really been rolled out well there. I think Israel are a shining example of a country which has vaccinated their own population, although of course there are still issues with the immunization of the Palestinian population in Israel, but they've done very well with their own population. I think Chile have done well, actually, interestingly enough, but I think I believe they've been using both some of the Chinese vaccines, which the evidence doesn't seem to be very forthcoming about the effectiveness of that, and so I do worry about those particular Chinese vaccines. But yeah. I mean, I think we want the world to do well. I mean, this is a global pandemic, and we all want our lives back and be able to travel to different parts of the world. And it's going to be difficult if there are pockets of the pandemic still raging in different countries.
Just picking up on that point about Chile, I mean, Israel is the biggest success story, and their rate of COVID is down so low because they've nearly vaccinated everybody, in at least the Jewish population in Israel. Whilst Chile is also vaccinated a large proportion of the population, but they're still seeing a lot of cases. So you think that might be that they've chosen the wrong vaccine?
I mean, I really don't know. I think the Israelis have used the Pfizer vaccine. I think Chile have used some of the Pfizer vaccine, but I think they've been using a lot of the Chinese vaccine. But of course, Chile is landlocked with adjacent to other countries like Argentina, Brazil, where there is a huge, particularly in Brazil, huge prevalence of the virus, and many people very severely ill with emerging variants there. So it's probably a very complicated geographical situation, as well as as well as their choice of vaccine.
Oh, sure. It isn't only vaccine. And I think, there's a debate at the moment whether it's vaccine or whether it's lockdown that has been responsible for our good position. I think the Prime Minister said in his briefing it was mainly lockdown, but people like Tim Spector, whose opinion I respect, say it's mainly the vaccine. But do you have a view about which has been more important in getting our caseload down?
Yeah, I don't have a view about proportionality, but I do think that they are both important. And clearly the vaccination program, to get people vaccinated is clearly important, but then so are social distancing measures, and the lockdown has been incredibly important. And the thing I worry about the most is that, that we are locked down too quickly, and then we see infection rates rise, and then we get more transmission, and then we get more variants that we see. So I do think that we need to all still be very cautious. Yeah, even though we're pleased about getting our freedoms back, I still would urge the public, who have been fantastic, really good, just to carry on being cautious and just take it slowly, step by step. And then if we can get our immunization coverage up so that we can offer every adult in the population a vaccination, then I think we'll be in a much better place. So, Roger, I think they're both important.
Sure. I think you were quoted in saying that some of the young people were going completely crazy once they'd got out of lockdown.
That's a misquote. I didn't say that young people were going crazy. I said that there were scenes in London on the media of people packing themselves outside in the outside space in pubs, and we just got to be wary of social distances. I mean, I do think the young people have been really remarkable. I think young people have made huge sacrifices, mainly because we know the disease isn't so severe in the young. Or I think they'd be mainly making their sacrifices to protect the older population. So far be it from criticize young people. I think young people have been really good during this pandemic.
Okay, well, I'm sure they'll like that message. Now, a little bit before we get on to vaccine safety, I'm getting loads of questions about thrombosis, of course, with the AZ vaccine and also with the Johnson & Johnson vaccine. But let's talk a little bit about the vaccine hesitancy, because we've got about 5% of people who haven't had the vaccine and are not going to have the vaccine. Is that right? But that's about 1 million people out of the 30 million or so who've had the vaccine.
Yeah, I mean, there's a great difference between hesitancy and refusal, isn't there? Yeah. And so hesitancy implies that there are people that could still be persuaded to be vaccinated that haven't taken it up yet, and we would carry on working at that very hard. There are problems. I mean, although we've got very good coverage, particularly in the over 70s, 95% overall, there are problems in London where the coverage rates are lower. There are problems amongst certain ethnic minority groups, such as Black Africans, where the rates are low, and we still need to do a lot of work with those groups. So we, NHS England worked very hard at actually working through localities in terms of community leaders, in terms of clinical local leaders, in terms of faith leaders, to try and actually persuade those that are hesitant to have the vaccine without being heavy-handed on those that are reluctant to have that refuse to have the vaccine. So all these strategies are important, really, and we will carry on reaching out to those groups, because we do know that if you have low vaccination rates in a community, you will experience at some point local episodes of infection and transmission, and that will be potentially very damaging. So we do want to work. We do want to reach out to all these groups that are hesitant at the moment.
There was a report yesterday that the Chelsea and Westminster Hospital is going to force its workforce to be vaccinated, and there was an issue about old people's homes as well, care homes as well. I mean, any thoughts about that? No jab, no job. Is that ethical to do that? Is it legal to do that?
I mean, I think that there's two elements to this. There's those that are already in the jobs, and I don't know about the legalities of that, but those that are applying for the jobs, it may become an occupational health requirement to be immunized before you're appointed to either being somebody working with vulnerable older people or vulnerable people either in the hospital or social care sectors. So I can sort of see that coming. I think it's very difficult, I would think, from an employment perspective, to make vaccination compulsory to those that are already employed without a change of government legislation on that.
Yeah. Well, surgeons like me have to be vaccinated against hepatitis, and nobody complains about that. Just to prove that I'm looking at your questions as they come through, thank you, got 41 so far. Danny Allen points out that Israel's offered vaccines to the entire population, which includes 25% of the population who are not Jewish. The percentage not vaccinated is children. And Karthik Kanan points out that Chile is not a landlocked country. It's got a rather nice coastline. So picking you up on that.
Okay,
but what about?
Yeah. Maybe my terminology is not right, not landlocked, but I meant close to other countries. And I don't know the data in Israel. I'm really pleased to hear that the Palestinian population. I mean, I thought there were problems with the Palestinian coverage earlier on, but pleased to hear that that's improving. Yeah.
Yeah. What about vaccination in children? Because we had Chris Whitty on this program with Simon 2 weeks ago, and Chris Whitty, made the point about the safety issues versus the benefit issues. And when children don't seem to suffer from COVID, it's rare to get bad COVID in children. They may transmit it, but they don't get ill with it. So the risk of vaccine versus the benefit is that there's a different calculation for children, right? So what's the JCVI think about vaccinating children?
Well, I mean, of course, we do know, as you said, that children get a very mild form of illness in the main, though long COVID is described in children and is currently being studied. None of the vaccines at the moment are licensed. I think Pfizer's licensed from 16 onwards, but they're not licensed for children, although there is emerging data to suggest that in adolescents that they're fine. So we need to see the efficacy data, we need to see the safety data on these vaccines. But the big problem is, of course, you'd be mainly immunizing children for indirect benefit of others. So it wouldn't be so much for direct benefit for themselves as protection for against transmission. And so you need to be absolutely ethically sound about this in terms of the safety and the efficacy of these vaccines in children before you went out and immunized children en masse.
And a couple of questions about pregnant ladies. Should you withhold the vaccine until the baby's born in that situation, Anthony?
Well, we've been quite clear on JCVI about this. I mean, there's a lot of evidence now emerging of the safety and efficacy in pregnant women in the States in using the Pfizer and Moderna vaccines. We've been quite clear that those pregnant women that whose risk of COVID or complications is significant, they ought to be discussing the benefits of the vaccine against potential risks. I mean, the problem earlier on was that, of course, none of the trials included pregnant women, and so we just didn't have the safety data on them, which is accumulating, as I say, in the States at the moment, but we're still looking at it quite carefully in the UK. We haven't. So pregnant women, if their clinician or obstetrician thinks they are at significant risk of COVID and complications, and they fit into an eligible group, should be immunized.
Well, time's moving on, and I do want to get into the safety issue, but there's so many interesting questions coming through. Mark Glasgow is asking about, thank you, Mark, the Sputnik vaccine. Is it the same carrier as AstraZeneca? Hungary, he says, has gone for this. And is there any evidence, apart from the fact that President Putin's given it to his daughter, that it actually works?
I don't know about the evidence that it works, but it is an adenoviral vector vaccine. In fact, I believe that they use two adenoviral vectors, one for the first dose and a different adenoviral vector for the second dose. Given the small number of cases with the Johnson & Johnson vaccine in the States, and given the signals that we're seeing in relation to the AstraZeneca vaccine in this country, obviously that would have to be monitored very carefully in terms of whether this is a safety signal, which is, and it's only a strong possibility at the moment that it's linked to the vaccine, but it's looking increasingly likely that it's a viral vector platform effect rather than a vaccine specific effect.
Mm-hmm. Let's talk about that, because there's loads of questions coming through about the thrombosis from that's been seen with AstraZeneca and now with Johnson & Johnson. They've just stopped the rollout of that in America, although they've given a lot of doses in America. So I know you're not a hematologist, and we wouldn't expect detailed analysis of exactly what's happening, but I think there's a lot of concern about that, and a lot of the doctors watching this program, well, not just doctors, the healthcare professionals watching this program, are wondering what to say to their patients about it. So in relation to the AZ vaccine, which is still being administered in many cases in the UK. So your thoughts about that and the JCVI.
Okay, so this is we need to get into context. We are giving millions and millions of doses of these vaccines, and this is a very, very rare safety signal. We don't know what the incident rate is. The safety signal seems to be surrounding thrombosis, and that could be venous or arterial, and thrombocytopenia. And the MHRA have come up with a very tight case definition of a probable case being a thrombocytopenia, that's platelets below 150, a D-dimer of greater than 4,000, and a thing called a positive platelet factor 4 antibody. So what happens is that these individuals, as you say, Roger, I'm not a hematologist, but seem to be getting what's called a HIT-like effect. So we do know that heparin can induce thrombosis and thrombocytopenia in some individuals quite unusually. And it seems to be a similar sort of mechanism to that, though we're not absolutely clear about the mechanism, but a similar sort of clinical pattern to that, I should say.
Right.
And so the really important thing about this is, one, that we get a clear idea of the incident rates in different parts of the population, and also that we get a message out to particularly the hematology community, and the hematologists have been quite good about the treatment of this particular rare side effect, because it's all a bit counterintuitive. If actually you give them platelets, you can make the condition worse, even though they've got low platelets. It's really important to treat them with immunoglobulins and non-heparin like anticoagulants. So there is a treatment message there. But from a vaccine point of view, what we want to look at very carefully on JCVI is the incident rates in different parts of the population, because of course the risk of clots from COVID is far greater for the majority of people that have been offered the vaccine, in fact for the vast majority of people that have been offered the vaccine, than the risk of the potential rare side effect. And so we don't want to stop the vaccination program in these risk groups that we've identified, but we have said at the moment that we want to be cautious for the well under 30-year-olds, and we will carry on looking at that data to see whether we need to extend that or not to a slightly higher age group. That we're not sure at the moment, but we are monitoring this on a daily basis. It is a worry, but getting into context, you're still much more likely to have a severe clot and from COVID itself than the vaccination.
And so I guess that raises the question: if you've had your first AZ dose and you really don't want a second AZ dose, can you mix and match and next time have a Moderna vaccine or a Pfizer vaccine or whatever other vaccine?
There's two parts to that question, Roger. One is that it's quite reassuring to see that we haven't seen any cases in the second dose yet, although we've only given 1 million, I know, but that's quite reassuring in a sense. And this may just be an idiosyncratic effect to that first dose of AstraZeneca. So we're certainly not advising people not to have that second dose. If you've had the first dose of AstraZeneca, you should be confidently able to have the second dose of AstraZeneca. Now, in terms of mixing schedules, that's an interesting question. There's lots of work going on, led by Matthew Snape in Oxford at the moment, looking at those that have received a first dose of the Pfizer or the AstraZeneca, receiving a second dose. It's a randomized trial, a blinded randomized trial, receiving a second dose of either the AstraZeneca, the Pfizer, the Novavax, or the Moderna vaccines. And so we'll get some idea about, I mean, the study's not looking at efficacy, it's looking at immunogenicity, both in terms of neutralizing antibodies and T-cell responses, and it's looking at reactogenicity, so whether you get some localized side effects or not from the vaccine. But if we can mix and match the schedules, that would be tremendously helpful in terms of flexibility of the program. And of course, moving forward, it may be that they give you better long-term protection if you mix schedules. That we'll need to find out. And it will also have implications to any potential booster campaign that we do in terms of what booster vaccine we offer people, which may well be a different vaccine than the one they've already received.
And I'm in Wimbledon at the moment where I live, but literally down the road, Wandsworth and into Lambeth, and some cases up in Barnet, I think, now, and across in East London too, of the South African variant. I mean, of course, it's a massive concern to everybody that variants will come along, possibly the Brazilian P1 variant, the South African variant, which are resistant to vaccines, to vaccination. So people who thought they were safe are no longer safe because of the variants. And there's a sort of massive queues to get surge testing done just down the road. So what are your thoughts about that? And what does the JCVI think about changing the vaccine so that it does cover the variants as they crop up?
Well, I think the companies are all working quite hard at tailoring or editing their vaccines to be effective against the variants. We do know that the vaccines aren't quite as effective against the South African variant in terms of preventing disease, although they do seem to be pretty good at preventing severe disease, hospitalizations and deaths. When you look at the laboratory studies, actually the neutralizing antibodies are pretty good against the wild strain, the Kent variant, and actually the Brazilian strain, but not so good against the South African strain. So we really don't want the South African strain to become too prevalent in this country, because we may start seeing some vaccine escape, and then we would need to tweak and edit the vaccines. But that's something we may well do for an autumn booster campaign if we decide to do that.
Actually, there's a question about David Rogers. Thank you, David. Is the size and shape of a likely booster program emerging? GPs need some clarity about their capacity if they're to play a part in this. I mean, any thoughts on autumn boosters?
Well, we haven't made any decisions on this yet, and that's the honest answer. It may be that we do an autumn booster campaign directed at those first 4 priority groups. So, those that we know that are hugely at risk of hospitalizations and deaths. And of course, traditionally vaccines don't work, although these vaccines seem to work very well in the older population. Traditionally, antibodies can drop off a bit more frequently in the older population. So we may decide to target this booster vaccine campaign, but we have not decided. And as soon as we've decided and got the evidence for making that decision, we would, of course, announce it to allow people to prepare. And we do realize that there are operational considerations which GPs and their teams just need to know, but we can't make the decision until we've seen all the evidence.
Yeah, thanks. Dania Glazer is saying, what's the effectiveness of vaccines in immunocompromised people? That's a good question, actually, isn't it? So lots of immunocompromised people around, chemotherapy, et cetera, et cetera.
The answer to that is, again, it's pretty evidence-free. There was a study in King's, and there's been other work that's going on. And it may be that those that are immunosuppressed don't have as much protection from either 1 or 2 doses of the vaccine. So it's one of the reasons that we decided on JCVI that, given that the emerging evidence that the vaccines do prevent transmission to a certain extent, that we would offer vaccination to those household contacts of immunosuppressed individuals to try and give them a little bit of cocooning protection within their household. But yes, it's an ongoing live question. We will be reviewing this data next week, I think, about immunosuppressed, and possibly even the week after, because we really want to make policy based on evidence. But at the moment, that evidence is just lacking.
Mm-hmm. I can't find the question now. They've got 86 questions coming in, but there's thank you for this question about people whose occupation puts them at particular risk. And I think there's some people thinking that the police, the bus drivers, the people who are subject to mixing with crowds as part of their occupation, shouldn't they have been given priority of vaccination?
Well, we looked at this very carefully. One of the reasons that the vaccine program has been so successful is because we've been able to roll it out at speed. Rolling out at speed is because of the simplicity of the program. Given that the predominant risk factor that outweighs any other is age, we decided to go through an age-based process for phase 2 rather than an occupational phase. We do know that obesity, male sex, and ethnic minority are risk factors as well. When you start looking at occupations, it becomes very difficult. Possibly the most at-risk groups are not those that you would imagine, and those are working in closed environments such as meat processing factories, or working within the catering industry, or working within the transport sector, are much more actually at risk from the data of getting COVID than the teachers or the police, actually, interestingly enough. But we decided that because the record of occupation isn't widely recorded within the primary care records, and because the data is uncertain, and because picking out one occupational group above the other may actually end up stalling the program while people decide who's in which group, we decided a simplicity and a speed-based approach was the right one.
Yeah, I can understand that. Vanisha Hirani says, how safe are these vaccines for autistic children or individuals with special needs? Because I guess, they may not be making the decisions themselves about whether to get vaccinated. Somebody has to do that for them. What are your thoughts about that?
Well, I mean, of course, we're not immunizing children at the moment, so we don't know the answer to that question. There's no evidence that these vaccines are less safe in those with learning disability, those adults with learning disabilities. And in fact, we decided that those with severe and profound learning disabilities should be immunized within cohort 6. And there is a special group, of course, is all those with Down syndrome, who are hugely at risk of COVID and the complications from COVID, possibly due to accelerated aging. We don't fully understand, but we put them within the first 4 priority groups, so they were in priority group 4. So in answer to the question about safety, there's no evidence that these vaccines are less safe in those with disabilities. We're not immunizing children at the moment, and we have prioritized those with severe and profound learning disabilities.
And do you think you will be eventually vaccinating children? Will we get to 100% of the population vaccinated, Anthony?
I think as we accrue more information about these vaccines and their safety, I think it's likely that we will have certainly an older children's immunization program at some point. I think that would be my personal judgment. That's not a JCVI view. That we'll be immunizing older children. Younger children I'm less certain about. but I think probably we'll be immunizing older children at some point.
Yeah. Well, we've done 40 minutes. You said at the beginning you weren't sure that there'd be enough to talk about, but actually there's a whole load more. And there are 98 questions now. You've almost had as many questions as Chris Whitty. So I think we should employ you to do your own TV chat show. You're such a seasoned media expert now. So let's just finish then on a positive note. I mean, I think, we've said that there should be a shout out for Kate Bingham, the task force, for the JCVI, especially for the volunteers and the general practitioners and the pharmacists who've done such a brilliant job. I mean, one thing, that you're especially proud of with what's been achieved in the UK?
Well, I'm proud of two things. I'm proud of how we've delivered this vaccine program. I'm particularly personally, because I'm a GP, I'm really proud of primary care and how it's stepped up to the mark for this vaccination program. So I'm really, really proud of that. But I'm also really proud about how the population have embraced the vaccine and how staggeringly high coverage rates we've got. I mean, this is really, really a combined effort between the health professionals and those that receive the vaccine. And I think, as you said earlier on, I think the press have got a tremendous part in this, because they have been very supportive and they have been very measured in their reporting of the whole program. So yeah, I'm proud of our country, Roger. I think we've done, this is now become a badge of honor, the immunization program. It's something which we have collectively achieved, and we should just press on and keep it going. It'd be really good.
After a shaky start, we're a beacon now to the rest of the world. So thank you so much, Anthony, to giving us so much of your time. You're really lovely to talk to you. You're one of the easiest people to interview that I've encountered. So just don't go away, because a few announcements to make. Next week, we've got Henrietta Bowden-Jones is chairing, and she's talking about COVID and mental health. Which I guess involves long COVID and the way that the virus impacts on the brain. And she's got some brilliant speakers: Neil Boyce, Professor Paul Harrison, and Nizween Alwan, who's on Twitter almost every other day with tweeting about COVID and so on and so forth. The day before that, we have our Wednesday evening In Conversation live series. And I'm very pleased to say that we've got to Professor Leslie Fallowfield, who more or less single-handedly explored the way that a diagnosis of cancer is explained to the patient, breaking bad news about cancer, looking after patients with cancer, and I suppose that could be applied too for severe COVID. So we'll be talking about issues of communication to patients by healthcare professionals. And then I should remind you about we're quite proud of our climate change series that we've been running at the Royal Society of Medicine, thanks to a very generous donation from Michael Rapp. We've had 3 climate series sessions so far, and the next one is climate change in cardiac health, the impact of rising temperatures on cardiac health, and then we'll be talking about mental health and other aspects of climate change. So that is on the 27th, Tuesday the 27th, at 6 o'clock in the evening. So you might want to put that in your diary. So back to Anthony again. Anthony, thank you so much. And thank you for all those who've tuned in and registered for this meeting. 99 plus questions now. I'm so sorry we didn't get a chance to answer more of them for you, but we simply ran out of time. We will look at them all. And I hope you'll join us next week for COVID and mental health with Henrietta. Have a wonderful afternoon, everybody. Bye.
Bye.